Good morning, everybody. It's a real pleasure to be here. As Andrew said, I practice in private practice in Pittsburgh, Pennsylvania. It's an honor to be here. I thank the program committee for involving me. So I'm going to be discussing this morning the so-called High Smas Facelift with an extended Platysmal Suspension. I have nothing to disclose. Nobody pays me anything. So in terms of the presentation contents, I'm going to be discussing a little bit about the historical development, and I'll certainly key into sort of where I came under the influence of some elderly but well-established facelift experts around the country, and I'm deeply indebted to them. So I'll talk about history and development, and then the rationale and advantages proposed for the high smas approach to facelifting. Also talk about some of the disadvantages. Disadvantages potentially for the patient, but also when I say logistical, I mean some of the costs in terms of time and effort to follow this approach. And then we'll talk a little bit about technique, show some of examples of my work in doing this, and then draw some conclusions. Okay, so in terms of the development of the high smas technique, this technique, as some of you may have heard of, it's been developed by a number of individuals. Dr. Fritz Barton down in Dallas, Texas, in the 80s, developed a lot of the fundamental thinking around this. And then more what I've been exposed to, Dr. Bruce Cannell and a number of his colleagues and pupils around the country, Tim Martin and such, have widely disseminated this way of thinking in terms of manipulating the smas. I spent some time with these individuals, and that's been very informative and instrumental in my way of thinking about facelifting. The one assumption, of course, people who try to contribute to sort of the underlying evidence base, you could say, for facial plastic surgery understand that there's not a lot of hard data, there's not a lot of evidence base to support a lot of what's being discussed today by all of us. And therefore, you have to draw certain assumptions or accept certain givens really even to begin, some parts of these conversations. So let's just say if you're going to be enthusiastic about pursuing a high smas approach to facelifting, you'd have to perhaps accept the assumption that you believe that dissecting under the smas, elevating and mobilizing the smas is a constructive thing to do and results in better results over the long term. And that's as opposed to doing, for instance, a skin-only facelift or plication or imbrication. And I'm acknowledging that the data is not necessarily authoritative to support that. So if one does accept the superiority of dissecting under the smas and doing a so-called deep plane approach, then you're left with a number of questions that sort of lead to one's thinking about the high smas versus other alternatives on how one could manipulate the smas. And so where does one exactly incise the smas? This is the most fundamental question. Where do you incise the smas and why? To what extent do you undermine the smas? What ligaments are critical to release in order to mobilize the smas appropriately, not just around the jawline or the mandible, but higher in the mid-face of the eye and such. And what vectors might you entertain in terms of moving the smas? Dr. Chacon has spoken elegantly over the last 2 years about certain vectoring and I think a very good effort to look at angulation in different age groups and what have you. This is a thoughtful exercise that we should all engage in. Answering these three questions and an array of other details encompasses a lot of the development of this high smas technique over the last 30 years. And so, there are many places that you can make these incisions. Every surgeon has their own preferences, but let's, for the sake of argument, assume that this is one putative approach that one might take if you were incising the smas, preparing to do a deep plate lift with a so-called low smas approach. And so the critical point here, here we go. Laser pointer. The critical point here is that the horizontal aspect, if you choose to make the horizontal aspect in manufacturing of the smas incision, is definitively below the zygomatic arch. And therefore, if you're an advocate of the high smas approach, you would say that you get an outstanding result in terms of mobilization and support of along the jawline and the jowl area, and perhaps the lower part of the midface. Other people might suggest, well, hey, here's another way to go. You could incise the SMAS this way. Again, dealer's choice. You could argue that maybe this is a little safer even than the first variant, though I'd say the first variant is very safe if you understand the anatomy in doing the low SMAS, and has sort of a similar neighborhood in which you are maximally effective. And so the SMAS, low SMAS flap elevation is below the zygomatic arch. The disadvantages, you could say, would be to limited or reduced or no impact in the mid-face, the infraorbital region, often mandating separate mid-face procedures. Advantages might be that it's quicker than on what I'm about to present, and perhaps safer. You could argue it's safer. You're not hugging up close to the real danger zones of the facial nerve. So what about this high SMAS incision? So, the red is the previous low SMAS incision, and here we go. This is this little extension. And it's pretty obvious what we're talking about here. The idea is to go further north, and then as you go towards the eye, you're definitively either above or riding right along either the superior border or right on the apex of the zygomatic arch. And my little dotted oval, lopsided oval, is meant to indicate this is your zone of influence now. You are not just improving areas here along the jawline, into the neck, jowls, but you're getting a positive benefit here. I respect that there are different philosophies about this. Dr. Giacono could present a different approach by angulating the SMAS flap. We get a lot of benefit without fat transfer, etc., into the midface. But this approach would suggest that actually mobilizing and vectoring the fundamental support structure of the face, that being the SMAS, along a high SMAS vector, is more beneficial. This is, I apologize about all these lines, you might recognize this. This is out of Netter. We all read this in medical school. But this is just, again, for emphasis. Here's the zygomatic arch. We're a little north of that. Okay, so high SMAS incision. Repeating myself a little bit, SMAS flap elevate along the superior border or directly over the zygomatic arch. Advantages include improved upper cheek contour, enhanced sort of, you could say, fill of the infraorbital region with or without fat transfer. I do fat transfer sometimes. I do sculpture postoperatively. Sometimes it depends upon the preferences of the patient in terms of the speed of recovery. Increased support for the lower eyelid and superior correction. I'd say this is speculative in my view, but some people would suggest this of the nasal beautiful. Disadvantages, is it less safe? Some people would say, my goodness, when I was in my ENT residency program, you didn't go into that territory lightly. And it requires more time. There's a certain economic credentialing, I think, that we all do as surgeons, for us and the patient, in terms of what we do and what we don't do. What's maximally in the interest of the patient? We just want the darn best result 10 years from now. But then, we live in a practical world. How do you weigh these different needs that impose upon all of us? In terms of safety, I've done this many, many, many times, and we've never had an issue with the nerve. We've not had the slightest issue with the nerve. There is, there's actually somebody, I guess one of Dr. Barton's younger colleagues down at UT Southwestern published a paper specifically on this because it raises queries so often. And fundamentally, if you look at the anatomy of the product, the temporal fascia, their point here is simple. The frontal branch of the facial nerve is stuck down densely over the zygomatic arch. And in a very slender patient, I'm not suggesting not to be awfully careful, but in a very slender patient, even additional levels of caution are necessary. But in your normative patient, I think there's room to run here. It's safe. Okay, very briefly, a little digression. I mentioned these two gentlemen. I think the two most instrumental names with this technique. Fritz Barton, there is a philosophical sort of fork in the road here. He is very much an advocate of sort of the skoog or the composite flap in terms of doing this approach. On the flip side, Bruce Cannell and his numerous pupils, they talk about, and I adhere to. These are the folks who have influenced me so much. The lamellar approach, and their point here is pretty straightforward. Sure, the SMAS flap, as was mentioned earlier, can be thinner. It can be technically challenging. When you see these fellows raise the skin flap. This is the difference that I observed. They, sort of admonish this pushing scissors technique. Them raising the skin flap is an exercise in its own, and it's time consumptive. And they say when you find the Smas flap is thin, did you push scissors, or did you raise that skin flap like you loved it? They'll tell you every time it's the former. Okay, so they would more than happily trade this slightly friable Smas flap, and especially if they try to minimize that appropriately, for the advantage of being able to mobilize the Smas with different vectors and with different levels of tension than you do the skin, because they view this as instrumental to the outcome. Okay, a few further details, and I think as Dr. Giacono alluded to, there are many other details that I apologize we don't have time to go to. What happens when you need to go? What happens when you have tonic secondary plates? When do you consider doing a full lower platysmal transection, which I do, maybe a third of the time. These things are a little bit beyond, so the 10 minutes were allocated, but they're relevant to this procedure. This little thing here is something I might imagine that I sort of hybrided onto this procedure. The reality is there's not much new under the sun. Indeed, this exactly how technically to do this and do this safely, several of my colleagues who I spent time with, including this gentleman on my left, taught me how to do this and do it, I think, safer than I was, which is this extended direct incision straight through, as the video showed in Dr. Kona's presentation, straight down through the platysma, that far into the neck. I find that he's correct. You can sometimes avoid opening the neck medially and doing a plication here. And I think the technical point that I found so useful is this notion in this area of dissecting from known to known, which means you turn your scissors or some other blunt instrument anteriorly and inferiorly into the neck and lift the Smas, the platysma, clearly off the underlying fascia. And then when you cut through, it'll decrease this sort of the nervousness tremendously when you know the nerve is down. And I wasn't doing that previously, and I feel like a lot safer doing it now. So, high Smas incision with extended platysmal suspension, and just briefly, advantages. Presumably, if you're doing the high Smas, you're harvesting all of those advantages in terms of the mid-face, the infraorbital region. And I do think I now enjoy a better restoration of the neck, including what I perceive to be, no data of course, perhaps a more durable lift when I reposition that tissue posteriorly with that extended platysmal suspension. Disadvantages, more time still. And what about less safe? I covered that a little bit here with how to not harm the marginal mandibular nerve. Okay, so briefly some demonstrations of this, and I guess the point I'm trying to make is a fairly good rejuvenation in the mid-face. This is the lady 17 months status post High Smas Facelift with extended platysmal suspension. I'm running low on time, so I'm going to move somewhat quickly. Here's a nice lady from Pittsburgh, 13 months. Same thing. This lady had a little bit of fat transfer as well. And I know, again, the idea is we're getting some benefit in the mid-face, but we're also getting a fairly nice clean neckline and into the neck. I think it's very important to show your patient some of these pictures with the chin tilted down. It sort of increases the honesty of the presentation preoperatively. And so conclusions. Some of the points I've made. Low cheek Smas flap elevation perhaps neglects some areas in the mid-face, in the infraorbital area, in the nasolabial fold that can be improved by simply accessing those areas with an incision and with a vector that logically accesses it. Incorporating the extended platysmal elevation and suspension permits a more comprehensive and durable rejuvenation in the neck, medially and inferiorly particularly. And so, in my mind, is the argument to pursue this high Smas approach, is it compelling in terms of the risks and benefits? I think in terms of risks, for example, risks in terms of morbidity to your patient, in terms of the facial nerve, I feel very comfortable with that. I've not had problems. In terms of the disadvantages for the patient and the surgeon, I guess this is a little bit what I alluded to earlier. I think the patient, it is a longer procedure. These gentlemen that I've mentioned that I've been influenced by, virtually all of their patients, perhaps not all, but virtually all of them are admitted overnight, and that's just not for comfort. you got to admit these guys overnight if you're going to operate on them that long. And so there's a cost associated with that. There's a cost for the surgeon, there's a cost for the patient, and that needs to be considered. But I think in terms of a definitive rejuvenation of the face, I think it's a compelling place. Is that the only place we ought to think about? And certainly not. This the spectrum of approaches. Does every patient need this? Perhaps not. But I think they're good foundational principles here. Thank you very much.
Thank you for that thoughtful discussion.